I'll be presenting my project, the multimodal integration of clinical notes and MRI to predict primary progressive aphasia variants. I did this work under my mentor, Dr. Pedro Pinheiro-Sharp. So for some background, primary progressive aphasia is a neurodegenerative disorder characterized by the progressive breakdown of language abilities, the ability to speak, comprehend, due to primarily dementia. And there's three main variants that we looked at, which are each based on specific language impairment and the neurological presentation based on atrophy in the brain. So there's logopenic, semantic, and non-fluent, which each have separate characteristics. And the modalities of data that are used to inform these decisions are typically neuroimaging scans, which tell us about atrophy and brain structure, as well as clinical notes, which document language and cognitive symptoms. So with the recent advancement in multimodal modeling with the vision language models like CLIP from OpenAI, there's an ability to generate a shared embedding space for images and natural language, which can represent these heterogeneous clinical data samples in a shared space. So what I wanted to do using this was identify PPA subtype relevant clusters through these joint embeddings in the shared latent space. And I hope to see that the subtypes would cluster themselves naturally without any need for a classifier. So the way that it worked was that inspired by OpenAI's CLIP, the clinical note was separated into clinical findings, and then the brain images, which I use T1 weighted MRI specifically, were pre-processed. And then the embeddings were extracted using Brain IAC, which is a foundational model for MRI, as well as OpenAI's text embedding 3 large, which I access through UCSF Versa. Then these were combined into a shared latent space, and then we analyzed these clusters. So what the results look like for this is that using a cosine similarity function, which is how OpenAI's model was trained, we can see that there is some significant separation between the three variants of PPA. And with our AUC, we can see that there is more information being provided to clustering than each modality individually, especially when we look at the separation of two PPA variants individually. We can see there is a high performance with logopenic versus non-fluent separation being 0.817, and similarly with logopenic versus semantic and non-fluent versus semantic PPA. Additionally, I tried out some other methods for the isolation, for the combination of these two methodologies. And weighted averaging actually turned out to be the best method, showing that clinical notes and MRIs have complementary information that both can equally inform the diagnosis and decision of PPA diagnosis. So in general, multimodal integration here with clinical notes and MRI captured more subtype relevant information than the individual modalities, with really high performance in subtype discrimination. And these joint embeddings did form clinically meaningful clusters. And in the future, what I would like to do is better understand the features that are being interpreted to generate these embeddings, explore how different embedding methods might affect these modalities, and add more samples to this, obviously. And I would like to explore a similar method for patients who are not classifiable by traditional measures as outlined by Dr. Gorno-Tempini in these PPA-NOS patients to see whether these natural clusters can reveal meaningful patterns in these non-classifiable patients. Thank you.